1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh.
Okay.
Oh.
Imagine a mother comes into the triage unit, and she is, let's say, 28 weeks gestation.
Okay, so a very premature situation.
Right, exactly. She is in active premature labor. Every 3 minutes, her uterus is just contracting, totally threatening to deliver this profoundly premature infant.
Which is a terrifying scenario for everyone in that room.
It really is. And to stop these contractions, the medical team hooks her up to an IV and administers, of all things, an asthma medication.
Yeah, it sounds completely counterintuitive when you phrase it like that.
Right. And over the next few hours, her heart rate skyrockets, her hands begin to shake violently, and her blood sugar just spikes.
And we should mention, we are giving her a drug that actually carries an FDA black box warning.
Exactly. A drug linked in post-marketing surveillance to, like, 16 maternal deaths from catastrophic cardiovascular events. So the question is, why is this our protocol?
It's a great question. Welcome to the very murky, high-stakes world of off-label maternity pharmacology.
It's wild. But that is our exact mission today. If you are listening to this deep dive, you are likely stepping into the shoes of a clinical professional, maybe a nursing student, or a healthcare provider staring down a massive maternity exam.
Or a pharmacology exam, yeah.
Right. You have this absolute mountain of information to digest, and you just need to know what actually matters at the bedside.
Because maternity nursing isn't just about rote memorization, it's really about understanding the physiological why behind these interventions.
Exactly. So we are applying the Pareto principle to the clinical profile of terbutaline sulfate. We are hunting for that vital 20% of the material that will give you 80% of the clinical understanding.
The understanding you need to keep your patients safe and, absolute crush your exam.
Yes. But before we start pulling apart this clinical dossier, we do need to set a hard boundary on what we are covering today.
Right. Let's lay out the constraints of our sources.
So the source text we are analyzing today is incredibly dense on the mechanism of action, therapeutic windows, and maternal fetal safety warnings.
It is very thorough in those areas.
But, and this is a big but, it completely omits drug interactions.
Yeah, that is a huge caveat for anyone prepping for clinical practice.
Yeah.
You cannot practice safely in a vacuum.
Right. You must cross-reference your primary pharmacology textbook or your facility's drug formulary for those specific interactions.
Because combining this with other sympathomimetics, for instance, could be disastrous. But our focus today is mastering the physiological mechanisms.
And the life-threatening adverse effects, the administration protocols, and those vital nursing assessments.
So let's unpack this. Picking up the dossier, the very first classification listed for terbutaline sulfate is a systemic, short-acting, selective beta-2 agonist.
A SABA, which fundamentally is a respiratory drug.
Exactly. So the obvious first question is, why are we talking about an asthma drug in an obstetrics deep dive? We have to bridge that gap.
We really have to look at the cellular mechanics. And the key to that bridge, according to the text, is the word selective.
Right. The autonomic nervous system, specifically the sympathetic fight-or-flight branch, relies on adrenergic receptors.
We have alpha receptors and beta receptors.
And within that beta family, the two main players for our discussion today are beta-1 and beta-2.
Now, the classic nursing school mnemonic that you always hear is one heart, two lungs.
Oh, yeah. Every student learns that one.
Right. Beta-1 receptors are predominantly in the cardiac tissue, and beta-2 receptors are heavily concentrated in the bronchiolar smooth muscle of the lungs.
It's a great foundational tool, but it's incomplete. It actually tricks learners into thinking these receptors are geographically isolated.
Actually, they are, right.
Not at all. While the lungs have massive quantities of beta-2 receptors, those exact same beta-2 receptors are abundantly present in the smooth muscle of the uterus.
Which, if you think about it, makes total evolutionary sense.
How so?
Well, imagine you are running from a predator. You have this massive sympathetic fight-or-flight response. Your body dumps epinephrine, hitting all those beta receptors.
Right, you want your airways to open up so you can oxygenate your blood.
Exactly, which is the beta-2 response in the lungs.
Yeah.
But you also absolutely do not want to go into labor while you're literally sprinting away from a tiger.
That would be, very bad timing.
Right. So that same sympathetic surge hits the beta-2 receptors in the uterus, signaling it to relax and just halt any contractions.
That is the exact physiological pathway we are manipulating here. Terbutaline is chemically designed to mimic that sympathetic surge.
But with a strong preference for the beta-2 receptors over the beta-1 receptors.
Yes, and with almost zero affinity for the alpha receptors.
So the dossier outlines the exact cellular cascade once terbutaline binds to that uterine beta-2 receptor. And I want to get very granular here.
Please do, because pharmacology exams love testing the specific steps of this pathway.
Okay, so the text states that terbutaline stimulates the activation of adenyl cyclase.
Right. Adenyl cyclase is an enzyme embedded right there in the cell membrane.
And what happens once it's activated?
Well, once activated by that terbutaline receptor complex, it takes ATP, the primary energy currency of the cell, and converts it.
It converts it into cyclic adenosine monophosphate, right? Or KMP.
Exactly, cyclic AMP. The source notes, this is the crucial intracellular messenger.
So what does that rise in KMP actually trigger?
It triggers two distinct, very important actions. First, it enhances the efflux of calcium from the smooth muscle cells.
Meaning it pushes calcium out.
Yes, and simultaneously, it prevents extracellular calcium from flowing in across the cell membrane.
Okay, so it clears out calcium. What's the second action?
Second, it inactivates an enzyme called myosin kinase, which effectively stops the phosphorylation of myosin.
To understand why that matters for your exam, we have to look at how a muscle actually contracts in the first place.
Right. Whether we are talking about skeletal muscle like your bicep or smooth muscle like the uterus, contraction relies heavily on calcium.
When intracellular calcium levels are high, that calcium binds to a protein called calmodulin.
And this calcium-calmodulin complex activates that myosin kinase we just talked about.
The kinase then phosphorylates the myosin heads, allowing them to bind to the actin filaments, pull, and create a physical contraction.
So, simply put, if there is no calcium inside the cell, there is no binding.
No binding, no activation of myosin kinase, and physically no way for the actin and myosin to cross-bridge.
The muscle is basically paralyzed in a relaxed state.
It really makes me think about how we use other drugs in obstetrics, like nifedipine, which is literally a calcium channel blocker.
Oh, that's a great comparison.
Right. Nifedipine shuts the door to calcium directly. Terbutaline is essentially doing the exact same thing, but through a backdoor signaling pathway.
That is a highly accurate clinical parallel. Think of the uterine smooth muscle cell as a high-security club.
Okay, I like this analogy.
Calcium is the hype man. You need the hype man inside to launch the contraction party. Nifedipine works by just barricading the front gate so the hype man can't get inside.
And terbutaline.
Terbutaline hacks the internal security system. It boosts TAM-MP, which acts like an internal bouncer.
So the bouncer actively escorts any existing calcium hype men out the back door.
Exactly. That's the enhanced efflux. And then it changes the locks on the front door to prevent any new calcium from entering. Without those guys, the party of the labor simply shuts down.
That perfectly clarifies the mechanism. But I'm looking at this receptor profile in the text, and something isn't adding up.
What's the disconnect?
If we are supposedly using a selective beta-2 agonist to specifically target the uterus and lungs, and avoid the beta-1 receptors in the heart, why am I staring at a dossier packed with severe cardiovascular side effects?
Yes.
The list includes myocardial ischemia and arrhythmias. So is the drug not actually selective, or is the heart just getting caught in some secondary crossfire?
It is actually a combination of both. And honestly, this is a classic trap for nursing students who confuse the words selective with specific.
Break that difference down for us.
Terbutaline is selective, meaning it strongly prefers beta-2. It is not specific, meaning it doesn't exclusively bind to beta-2.
So as the dosage increases.
Exactly. As the dosage goes up, that selectivity diminishes. The drug begins to spill over and stimulate the beta-1 receptors in the heart anyway.
Which directly increases the heart rate and the force of contraction.
Yes. But there also has to be a hemodynamic compensation happening here, too.
Right, because beta-2 receptors are also located in the smooth muscle of the vasculature, the blood vessels.
So stimulating them is going to cause systemic vasodilation.
And systemic vasodilation causes a sudden drop in systemic vascular resistance, which lowers the patient's blood pressure.
And the body's baroreceptors immediately sense that drop. They trigger a compensatory reflex arc.
The brain tells the heart, hey, we're losing pressure down here. You need to pump faster to maintain perfusion.
Exactly. So you end up with reflex tachycardia on top of the direct beta-1 stimulation. It's a double whammy to the heart.
This is a massive piece of the puzzle for nursing management. You aren't just memorizing a list of side effects. You are tracing the logical, inescapable consequence of systemic beta-adrenergic stimulation.
You cannot separate them. The very mechanism that provides our therapeutic effect, uterine relaxation, is physiologically inseparable from the mechanisms causing vasodilation and cardiac stimulation.
You literally cannot have one without the other, which forces us to ask the most critical clinical question.
Why are we accepting these intense systemic consequences?
Right. What is the actual goal of giving this drug? Because the dossier lists the therapeutic indication as acute tocolysis.
Which means the inhibition of uterine contractions in premature labor.
But it explicitly notes that this is an off-label use. Terbutaline is FDA approved for the prevention and reversal of bronchospasm. It is not approved to stop labor.
And the off-label nature of this intervention is just the beginning of the clinical reality check you need for your exam.
Yeah, our source cites the American College of Obstetrics and Gynecology, the ACOG, and they drop a rather staggering piece of data.
They really do. They state that a clear first-line drug for tocolysis simply cannot be recommended.
Even more importantly, they emphasize that tocolytics do not reduce the preterm delivery rate.
I need to pause on that because it sounds entirely contradictory.
Right. We are utilizing a powerful drug, accepting the severe risk of cardiac arrhythmias, to stop labor. But the data says it doesn't actually reduce the rate of preterm deliveries.
Meta-analyses show literally zero benefit in preventing a preterm birth from happening over the long term.
So why are we doing this? We subject the mother to a powerful drug just to buy, what, 48 hours?
We are doing it to buy a very specific, very narrow window of time. The ACOG and the source text clarify that while tocolytics cannot stop preterm labor permanently, they can prolong the pregnancy by approximately 2 to 7 days.
But buying 2 to 7 days doesn't sound like a victory if the end result is still a premature baby.
In the realm of fetal physiology, 48 hours can literally be the difference between a neonate who can breathe independently and one who suffers catastrophic respiratory failure.
Okay, wow.
The goal of that 2 to 7 day window is to facilitate two vital, life-saving medical interventions. The first is maternal transport.
Right, moving the mother to a facility actually equipped to handle a micropreemie.
Exactly. If a woman goes into labor at 26 weeks at a rural Level I community hospital, that facility does not have the ventilators or the neonatologists required to keep that baby alive.
That baby needs a Level 3 or Level 4 neonatal intensive care unit, a NICU.
But transporting a fragile 26-week neonate in an incubator via ambulance or helicopter is incredibly dangerous.
So the safest transport vessel for a premature baby is the mother's uterus.
Precisely. Tocolysis pauses the contractions just long enough to load the mother into a helicopter and physically move her to the tertiary care center before the baby is born.
The uterus is the ultimate transport incubator. That makes so much sense.
Oh.
And the source text points out the second critical intervention during this window.
The administration of antenatal corticosteroids.
This is where those 48 hours become absolutely paramount. When a baby is born prematurely, their lungs are severely underdeveloped.
Specifically, the type 2 pneumocytes in the alveoli have not yet produced sufficient amounts of surfactant.
And surfactant is that lipoprotein that reduces surface tension inside the alveoli, right?
Right. Without it, the tiny air sacs in the lungs just collapse and stick together every single time the baby exhales.
Which leads to severe respiratory distress syndrome.
To accelerate the production of that surfactant, we administer intramuscular corticosteroids to the mother, typically betamethasone or dexamethasone.
And these steroids cross the placenta and rapidly mature the fetal lungs.
But the process isn't instantaneous. It takes roughly 48 hours from the first steroid injection for the medication to reach its maximum physiological efficacy in the fetus.
So the terbutaline isn't the cure for preterm labor at all. It is merely the chemical pause button.
We are intentionally subjecting the mother's cardiovascular system to a massive stress test solely to buy enough time for the steroids to work and the helicopter to land.
That is easily the highest yield concept for any maternity nursing exam right there.
Absolutely. Test writers will consistently present scenarios where a patient expects the tocolytic to keep her pregnant until 37 weeks.
And the correct nursing action is always rooted in the reality that our goal is delay, not permanent prevention.
But, history tells us that the medical community didn't always view it that way.
Yeah. There was a time when providers absolutely tried to use this drug to permanently stop preterm labor.
And that hubris led directly to the most alarming section of this entire dossier.
The FDA boxed warning. The literal black box.
The black box warning on terbutaline is a masterclass in why post-marketing surveillance is so critical in pharmacology.
And why, quote-unquote, standard practice must always be subjected to rigorous safety data. So let's look at what the text outlines as strict contraindications.
Prolonged parenteral tocolysis, meaning continuous intravenous or subcutaneous infusions, is explicitly contraindicated beyond 48 to 72 hours.
Furthermore, oral terbutaline is completely contraindicated for both acute and maintenance tocolysis.
The FDA states it should not be used for the prevention or any treatment of preterm labor due to a profound lack of efficacy and serious maternal cardiovascular safety concerns.
Do not use in the outpatient or home setting, period.
To understand the weight of that warning, we have to rewind to the obstetrical culture of the late 90s and early 2000s.
What were they doing back then?
Well, providers recognized that subcutaneous terbutaline could acutely halt contractions, but instead of stopping at the 48-hour mark, they hypothesized that continuous low-dose administration could keep the uterus quiet for weeks or even months.
Wow. The dossier mentions historical doses where women were actually sent home taking 5 to 10 milligrams orally every 4 to 6 hours until they reached 37 weeks gestation.
They were effectively bathing their cardiovascular systems in a synthetic adrenaline analog around the clock.
And it went beyond just oral pills, right?
Oh, yeah. The medical industry actually developed modified syringe pumps, very similar to insulin pumps.
No way!
Yes. Pregnant women were sent home on bed rest, tethered to continuous subcutaneous infusion pumps, delivering a basal rate of 50 to 100 micrograms an hour.
With the ability to push a bolus dose if they felt a contraction.
Exactly. They were managing complex, high-risk, off-label intravenous therapy in their living rooms.
That's insane. Because earlier we discussed the systemic effects. This drug causes vasodilation, reflex tachycardia, and direct beta-1 cardiac stimulation.
And a pregnant woman's body is already undergoing massive physiological changes.
Right. Her blood volume naturally expands by 40 to 50% during pregnancy. Her heart is already working overtime just to pump that extra volume.
That hemodynamic reality is exactly why the prolonged use of this drug became lethal.
The FDA post-marketing surveillance eventually caught up to the clinical practice, didn't it?
It did. The dossier notes that 16 maternal deaths and 12 cases of serious maternal cardiovascular events were reported directly linked to terbutaline tocolysis.
16 maternal deaths. That isn't just a statistical anomaly, that is a definitive pattern of iatrogenic harm.
The mechanism of death in these cases usually stems from the cardiovascular strain. We're talking about myocardial ischemia,
Where the heart muscle is beating so fast and working so hard that it outstrips its own oxygen supply, leading to a heart attack.
Exactly. We are talking about severe cardiac arrhythmias and perhaps most insidiously catastrophic pulmonary edema.
Let's trace the hemodynamics of that pulmonary edema because it perfectly illustrates why prolonged administration is the breaking point.
Let's do it. So a pregnant woman has a massively expanded intravascular volume.
But her red blood cell mass doesn't increase at the same rate as her plasma volume, leading to physiological anemia.
More importantly, she has a relative decrease in serum albumin.
Which means her intravascular oncotic pressure is lower. The fluid inside her blood vessels is already primed to leak out into the interstitial spaces.
Now introduce continuous terbutaline. You induce severe tachycardia.
When the heart rate is constantly elevated, say 130 or 140 beats per minute for days on end, the ventricles just don't have enough time to fully relax and fill with blood during diastole.
And this inefficiency causes hydrostatic pressure to back up into the left atrium.
And subsequently back into the pulmonary veins.
Add in the fact that prolonged beta-adrenergic stimulation can trigger the release of antidiuretic hormone,
causing the kidneys to retain even more water. So you have a patient with expanded blood volume, lower oncotic pressure to hold the fluid in the vessels, and rising hydrostatic pressure backing up from a tachycardic heart.
Eventually, that pressure forces the fluid out of the pulmonary capillaries directly into the alveoli. The mother literally begins to drown in her own fluids.
This is flash pulmonary edema.
Yeah.
And in a home setting, it is rapidly fatal.
This is exactly why the black box warning exists. And it establishes a non-negotiable nursing implication for your exam.
Right. If a test scenario or a real-world clinical situation presents a provider writing a discharge order for oral terbutaline,
Or attempting to set up a home subcutaneous pump for maintenance tocolysis,
the nurse cannot proceed. You just can't.
the nurse is the final safeguard. You do not provide the discharge education on how to take the pills. You do not coordinate with the home health agency for the pump.
You halt the discharge process, hold the medication, and contact the prescriber to clarify the order.
And you directly cite the FDA black box warning against prolonged or oral maintenance therapy.
And there is another vital physiological caveat here regarding the kidneys, right?
Yes. Even if we are only using the drug in the acute 48-hour window in the hospital, we have to look at the patient's renal function.
Because the pharmacokinetics in the dossier tell us that roughly 60% of a terbutaline dose is excreted in the urine as unchanged active drug.
So if a patient has renal impairment, their kidneys cannot clear the medication.
And the drug begins to accumulate in the bloodstream.
And the risk of those lethal cardiovascular toxicities skyrockets, even within the acceptable time frame.
The dossier provides the specific parameters for adjusting the dose based on creatinine clearance, or CRCL.
If the CRCL is greater than 50 milliliters per minute, we consider that sufficient renal function. No dosage adjustment is needed.
But if the CRCL drops between 10 and 50 milliliters per minute, the kidneys are clearly struggling.
The protocol dictates administering only 50% of the usual systemic dose to prevent toxic accumulation.
And if the CRCL is less than 10 milliliters per minute, which is severe renal failure, the use of terbutaline is absolutely avoided. The risk of accumulation is simply too high.
So we've established the absolute boundaries. We know we are only buying 48 to 72 hours. We know we are never sending the patient home on it.
And we are heavily monitoring renal function. This brings us to the actual administration. When the decision is made to use this off-label intervention in the acute setting, how do we physically deliver it?
The primary route emphasized in the dossier for acute tocolysis is subcutaneous injection.
The historical off-label dosing protocol calls for 0.25 milligrams injected into the lateral deltoid area.
0.25 milligrams is a microdose in terms of volume, but the potency is profound.
The administration frequency ranges from every 20 minutes to every 6 hours, depending on the frequency and intensity of the uterine contractions and the mother's physiological tolerance.
The preparation guidelines note that the vials or ampules are for single patient use only.
The nurse must visually inspect the fluid for any particulate matter or discoloration before drawing it up and discard any unused portion immediately.
But I want to scrutinize the intravenous administration data in this text because there is a glaring contradiction here.
Yeah, it really highlights the chaotic nature of off-label prescribing. What stands out to you in the IV section?
The text explicitly states, in plain language, terbutaline is not FDA approved for continuous intravenous infusion.
Right. But in the very next paragraph, it provides detailed instructions on how to mix it.
Exactly. It says it may be diluted with 5% dextrose, 0.9% normal saline, or 0.2% normal saline to a maximum concentration of 1 milligram per milliliter.
Furthermore, it lists the ASHP recommended standard concentrations for pediatric continuous infusions at that same 1 milligram per milliliter ratio.
How can a drug be simultaneously forbidden by the FDA for continuous SABA, yet have standardized, widely published mixing guidelines for continuous FAV?
Especially in pediatrics. It's wild.
This is a phenomenal example of textbook theory clashing with the reality of the intensive care unit.
Right. The FDA regulates pharmaceutical companies. They dictate what a manufacturer is legally allowed to put on the label and market the drug for.
The manufacturer of terbutaline never funded the massive multi-million-dollar clinical trials required to prove to the FDA that continuous SABA infusion is safe and effective.
Therefore, the FDA cannot and will not approve that route.
But the FDA doesn't practice medicine. They don't stand at the bedside.
The FDA regulates drugs, not physicians.
A physician has the legal authority to prescribe a drug off-label via an unapproved route if they believe the clinical evidence and the patient's critical condition warrant the risk.
In extreme clinical scenarios, like an intubated pediatric patient in severe status asthmaticus whose airways are completely clamped down, physicians will order continuous IV terbutaline as a last resort salvage therapy.
And that is exactly where ASHP, the American Society of Health System Pharmacists, steps in.
They look at the reality of the hospital floor and recognize that, regardless of the FDA label, doctors are going to order this continuous IV in emergencies.
If every hospital pharmacy mixes it differently, the risk of a fatal medication error skyrockets.
It is entirely a harm reduction strategy.
ASHP publishes these standard concentrations so that when the off-label order inevitable comes in, the pharmacy compounds it safely, uniformly, and predictably.
As a nursing student, understanding this distinction is crucial because it demystifies why the orders you see on the floor don't always perfectly align with the black and white text of your pharmacology book.
Let's bring the focus back to our pregnant patient receiving that 0.25 milligram subcutaneous injection.
The dossier highlights a nursing parameter that is arguably the single most important data point for safe administration.
If you take absolutely nothing else away from this entire deep dive, commit this to memory.
Write this down.
Doses of terbutaline should be held for a maternal pulse of more than 120 beats per minute.
Hard stop. Hold the dose if the maternal heart rate exceeds 120.
It is a non-negotiable clinical threshold. We have established that terbutaline inherently causes tachycardia.
We have established the risk of myocardial ischemia and pulmonary edema.
If you approach a patient who is actively contracting and her resting apical pulse is 125 beats per minute, her cardiovascular system is already operating near its maximum compensatory threshold.
If you push another 0.25 milligrams of a systemic beta agonist into a system already running at 125 beats per minute,
you risk pushing the myocardium completely over the edge into an uncontrolled lethal arrhythmia or total decompensation.
this is the ultimate test of nursing autonomy. The provider wrote the order to stop the contractions.
The patient is frightened and in pain from the labor. The monitor is showing regular uterine activity.
Every external force is pushing you to administer the drug. But your assessment of that 125 heart rate supersedes all of it.
You hold the syringe, you document the vitals, and you notify the provider immediately. You are the gatekeeper.
Which transitions us perfectly into the broader clinical picture of side effects in nursing management.
Because once that drug is injected, the nurse's role shifts from administration protocol to relentless surveillance.
The side effect profile here is extensive, and we need to categorize it logically so it actually sticks for your exam prep. Let's start with the metabolic effects, because the maternal-fetal interplay here is fascinating.
The source notes that terbutaline causes transient maternal hyperglycemia, which subsequently leads to neonatal hypoglycemia.
I really want to trace the mechanism on this, because on the surface, it sounds contradictory.
It does.
If the drug spikes the mother's blood sugar, how does the baby end up with dangerously low blood sugar?
We have to look at the liver's response to beta-2 stimulation.
Okay.
When those beta-2 receptors in the maternal liver are activated, it triggers glycogenolysis.
The rapid breakdown of stored glycogen into free glucose.
The mother's liver dumps this glucose into her bloodstream, leading to a massive spike in her blood sugar.
And glucose is a relatively small molecule. It freely crosses the placental barrier. So the mother's hyper-sweetened blood flows right into the fetal circulation.
Exactly. The fetus is suddenly swimming in an incredibly high glucose environment.
But the fetal pancreas is perfectly healthy and fully functional, right?
Yes, it senses this massive sugar load and does exactly what it is supposed to do. It dramatically ramps up insulin production to drive that glucose into the fetal cells.
So in utero, we have a fetus with high blood sugar and correspondingly high insulin levels. It's an artificially inflated equilibrium.
Then the moment of birth arrives. The baby is delivered and the umbilical cord is clamped.
And that cord clamp is the ultimate sugar rug pull. The constant high-volume supply of maternal glucose is instantly and permanently severed.
But the neonate's pancreas doesn't know the cord has been cut,
It is still operating on the physiological data from 5 minutes ago.
pumping out massive quantities of insulin to handle a sugar load that no longer exists.
This massive surplus of insulin rapidly scavenges whatever residual glucose the baby has in its system, plummeting the neonate's blood sugar to dangerous, potentially seizure-inducing depths.
This is profound neonatal hypoglycemia.
The nursing management here requires a dual approach. You are monitoring the mother's capillary blood glucose during the terbutaline infusion to ensure she doesn't require insulin coverage.
But more importantly, the neonatal intensive care team must be ready the moment that baby is born.
They will be performing serial heel-stick glucose checks on the neonate and closely observing for clinical signs of hypoglycemia.
Like jitteriness, a high-pitched cry, lethargy, or poor feeding.
Now, the other major metabolic disturbance we must monitor is hypokalemia, a drop in serum potassium.
Usually when we think of a drug causing hypokalemia, we think of a loop diuretic like furosemide.
Where the potassium is physically excreted out of the body through the urine. But that isn't the mechanism here, is it?
No, the total body potassium doesn't necessarily change with terbutaline. It is a shift, not an excretion.
Okay, explain that shift.
Beta-2 stimulation actively ramps up the sodium-potassium ATPase pump on the cell membranes throughout the body.
This pump aggressively pulls potassium out of the intravascular blood serum and shoves it into the intracellular space.
So if we draw a metabolic panel, the serum potassium level will appear dangerously low, even though the potassium is just hiding inside the cells.
This shift is critical because low extracellular potassium increases cardiac excitability, further compounding the risk of arrhythmia as we discussed earlier.
And it creates a secondary nursing implication: rebound hyperkalemia.
Oh, right. If a provider aggressively replaces that quote-unquote missing potassium with IV supplements while the patient is on terbutaline.
What happens when the terbutaline is finally discontinued?
The beta-2 stimulation stops, the sodium-potassium pumps slow down, and all that hidden potassium rushes back out of the cells into the bloodstream.
If you supplemented them heavily, they will suddenly shoot into severe hyperkalemia.
Precisely. Managing these metabolic shifts requires nuanced understanding. Moving on to the cardiovascular side effects, we see sinus tachycardia and palpitations occurring in roughly 5 to 23% of patients.
We also see STT wave changes and premature ventricular contractions, or PVCs.
We have spent a lot of time on the mechanics of pulmonary edema, but I really want to ground this in practical nursing assessment.
Okay, let's bring it to the bedside.
A pregnant woman in her 3rd trimester is carrying an expanded uterus that is physically pushing up against her diaphragm. She is going to experience shortness of breath under normal circumstances.
She is also going to feel her heart racing due to the sheer anxiety of premature labor.
Exactly. So how does a bedside nurse differentiate between the expected discomforts of a high-stress pregnancy and the onset of a lethal terbutaline-induced cardiovascular event?
It all comes down to meticulous auscultation and recognizing the specific signs of fluid overload.
Normal pregnancy dyspnea is mechanical. The lungs just don't have room to expand. But the lung fields themselves are dry.
When you place your stethoscope on the bases of the lungs of a healthy pregnant woman, the breath sounds should be clear.
But if the hydrostatic pressure has forced fluid into the alveoli, if pulmonary edema is developing, what are we hearing?
You will hear crackles, historically called rails. It sounds like rubbing strands of hair together right next to your ear, or like Velcro slowly pulling apart.
Ooh, that's a perfect description.
The fluid bubbling in the tiny air sacs creates this distinct acoustic signature.
And visually, the patient's presentation will change drastically. It won't just be a general feeling of breathlessness.
No, pulmonary edema is a suffocating crisis. The patient will likely experience severe orthopnea,
Meaning they literally cannot breathe when lying flat and will demand to sit bolt upright.
You will also see a sudden, unexplained drop in their oxygen saturation on the pulse oximeter.
In severe advancing cases, the sheer pressure in the capillaries will cause microscopic bleeding into the alveoli.
Resulting in a cough that produces a classic pink frothy sputum. If you see pink froth, you are in the middle of a massive medical emergency.
This dictates an aggressive nursing assessment protocol. You aren't just taking a blood pressure every 4 hours. You are continuously monitoring the maternal heart rate.
You are also continuously monitoring the fetal heart rate, looking for fetal tachycardia,
Yeah.
because that terbutaline crosses the placenta and stimulates the baby's heart as well.
And you are performing frequent, systematic auscultation of the lung bases.
Finally, we must address the neurological side effects. The dossier notes that tremor occurs in up to 38% of patients.
We also see nervousness, anxiety, headache, and dizziness.
I try to put myself in the patient's position. You are lying in a hospital bed, terrified that you are about to deliver a baby months too early.
The medical team injects a drug into your arm, and suddenly your heart is pounding against your ribs, your hands are shaking so badly you can barely hold your phone, and a profound chemical wave of anxiety washes over you.
That sounds like an absolute psychological nightmare if you aren't prepared for it.
It is deeply distressing, and it highlights a crucial non-pharmacological nursing intervention: anticipatory guidance.
You cannot simply administer this medication and walk out of the room. You must sit with the patient before the injection and explain exactly what is going to happen.
You tell them, Your heart is going to race. Your hands are going to shake. You're going to feel a rush of anxiety that might make you feel like you are having a panic attack.
This is not a complication. This is the expected chemical reaction to the medication doing its job to relax your uterus. We're going to monitor your vital signs continuously to ensure you remain within safe limits.
By establishing that expectation, you remove the terror of the unknown.
The patient will still be uncomfortable, absolutely, but they won't interpret the side effects as a sign that they are dying.
Let's follow this patient's timeline forward. We have navigated the acute 48-hour window. The betamethasone has been administered.
The patient was safely transported to the tertiary care center, and eventually the baby is delivered safely.
Now we move into the postpartum phase. Let's assume the mother has a history of asthma and relies on terbutaline to manage her bronchospasms.
Okay, very common scenario.
And she wants to breastfeed her newborn. What does the pharmacokinetic data tell us about lactation?
The source data confirms that terbutaline does distribute into breast milk. The molecules cross the mammary epithelium.
However, the concentrations found in the milk are incredibly low.
The dossier provides specific estimates. Based on studies of maternal oral dosing, an exclusively breastfed infant receives an estimated 0.2% to 0.7% of the total maternal dose.
We're talking about fractions of a single percent.
Because the bioavailability in the milk is so negligible, the American Academy of Pediatrics, the AAP, has historically categorized terbutaline as usually compatible with breastfeeding.
Clinical observation of infants nursing from mothers on this medication rarely shows significant adverse effects.
But the text presents a fascinating contradiction in the literature here.
While the clinical bodies like the AAP say it is usually compatible, the drug manufacturer's official guidance states that terbutaline should only be used in breastfeeding women if the benefit outweighs the potential risk to the newborn.
It sounds like they are heavily hedging their bets.
It is a perfect illustration of the divide between clinical observation and legal liability.
The manufacturer's legal team is writing that guidance. They know the drug is a potent beta agonist. Even if only 0.2% enters the milk, there is a non-zero chance of an infant experiencing tachycardia or tremors.
To protect themselves from liability, they use the strictest possible risk versus benefit language.
The AAP, conversely, looks at decades of epidemiological data and concludes that the overwhelming benefits of breastfeeding far outweigh the microscopic risk of trace drug exposure.
But the dossier doesn't leave the clinician hanging. It offers a highly practical alternative.
Expert panels recommend that for a lactating mother who needs asthma control, inhaled beta agonists like albuterol or levobuterol are vastly preferred over systemic oral or injected therapy.
It comes down to basic pharmacokinetics and first-pass metabolism.
If a mother takes an oral terbutaline pill, that drug must be absorbed through her gut, pass through her liver, and circulate through her entire systemic bloodstream before a fraction of it reaches her lungs to treat her asthma.
And that entire time, it is fully available to pass into the breast milk.
But if she uses an albuterol inhaler, the medication is delivered topically directly to the bronchiolar smooth muscle where it is actually needed.
The systemic absorption into the mother's bloodstream is incredibly small, meaning the amount that could potentially reach the breast milk is virtually non-existent.
The nursing implication here is a blend of advocacy and education. You advocate for the provider to transition the postpartum patient from systemic to inhaled therapy whenever clinically appropriate.
And you educate the mother. You teach her to monitor the infant for any signs of beta adrenergic stimulation.
Things like unusual jitteriness, a heart rate that feels too fast when she rests her hand on the baby's chest, or an inability to settle and sleep.
If she observes those signs, she must report them to her pediatrician immediately.
We have covered an immense amount of physiological and clinical ground today. Let's synthesize this into our Pareto 20%.
The absolute highest yield concepts a learner needs to walk away with for their exams.
Fundamentally, terbutaline sulfate is a systemic, short-acting, selective beta-2 agonist.
It achieves acute tocolysis not by physically blocking calcium, but by driving up intracellular CAMP.
That CAMP acts as the internal security system, actively escorting calcium out of the smooth muscle cell and locking the doors, rendering the uterus physically incapable of contracting.
The clinical goal is never ever permanent prevention of premature birth.
The goal is a narrow 48 to 72-hour window to allow for maternal transport to an NICU-equipped facility and the administration of fetal lung-maturing corticosteroids.
The drug carries a severe FTM black box warning. It must never be used orally for tocolysis.
And it must never be used systemically beyond that 72-hour window due to the proven risk of maternal cardiovascular death, specifically from myocardial ischemia and flash pulmonary edema.
When administering the subcutaneous dose, the absolute nursing hard stop is a maternal resting heart rate greater than 120 beats per minute.
If the pulse is over 120, you hold the drug.
And the bedside management requires relentless vigilance, listening to the lung bases for the crackles of pulmonary edema,
Monitoring for the intracellular shift of potassium leading to hypokalemia.
and preparing the NICU team for the inevitable sugar rug pull, maternal hyperglycemia driving fetal hyperinsulinemia, resulting in a dangerous crash into neonatal hypoglycemia the moment the umbilical cord is cut.
If you master those concepts, you aren't just memorizing facts for an exam. You truly understand the profound physiological impact of the medication on both patients involved.
As we close out this deep dive, I want to pose a thought for you to carry with you onto the clinical floor.
Consider the historical arc of terbutaline we discussed today. In the 90s, sending a pregnant woman home on a continuous subcutaneous terbutaline pump was considered innovative, standard practice, off-label medicine.
Providers believed they were saving pregnancies.
It took years of post-marketing surveillance and the tragic loss of 16 maternal lives for the medical community to recognize the catastrophic hemodynamic reality and issue the black box warning.
It forces a profound question about the nature of clinical practice today. What off-label treatments, what standard protocols are we accepting without question on our nursing floors right now that might carry their own black box warning a decade from now?
Medicine is constantly evolving, and sometimes it learns its most vital lessons in retrospect.
As a nurse, you are the final checkpoint before a drug enters a patient's body.
Your critical thinking, your willingness to question a standardized order, and your acute physiological observation at the bedside are the first and often the only line of defense in identifying those hidden catastrophic risks.
We started this analysis talking about the desire for pharmacology to be a perfect lock and key, a clean, predictable science.
But we've seen today just how murky the clinical waters truly are.
We're utilizing an asthma drug to paralyze the uterus, triggering a cascade of chaos in the maternal heart, the liver, and the fetal pancreas along the way. Memorization will not help you navigate that chaos.
But critical thinking, a deep, unyielding understanding of the physiological why, that is what clears the muddy waters.
Thank you for joining us on this deep dive. Take this knowledge, crush your exams, and bring that relentless questioning mindset directly to the bedside.